Good afternoon, everybody. Today we're doing ODD. This is not an ADHD webinar, but ODD. We're moving ahead. And what I want to do over these next several slides is to talk a little bit about the episode and how we came to these decisions. So the first slide, hopefully it's on the screen now, it says, in Arkansas, clients aged 6 to 17 account for 90% of non-comorbid clients in spend. And remember, the ODD episode will only account for clients who are between the age of 6 and 17, okay? Not younger than that, not older than that. And we'll get into some of that information in a little bit. So if you look on the left-hand side, you can say the breakdown of 3-month episodes with at least one ODD claim. Now, the first one is only one ODD claim. The second light blue box has episodes with a comorbid behavioral health condition. And the next one, the dark blue, is the one we're really interested in, because that's ODD only episodes with more than one claim. And if you look at that, if you follow that over to the right-hand side, it breaks down that 11.2 and shows you that of the 100% of this group, 41% are school age and 59% are adolescent. That's sort of the breakdown. And further over on the right, it shows you the spend of the 100%, which is 19 million for this group. 42% is school-aged, and 58% is adolescent. So the breakdowns between the numbers and the spend are very, very similar. Okay. Now, if we move on to the next page, next slide. Thanks, Shelley. It's labeled the same way, but what we want to show you in this one is the total universe. So even though the last slide showed just 6 to 17, this also gives you the tiny 6% for the preschool, and over on the further side, the 4%, and then the 2% of spend for adults. Okay, so that gives you the total universe, but the ones we're really interested in the middle two sections, the school-aged and adolescent. Okay. And this gives you a distribution of the number of non-comorbid ODD clients treated by individual providers. So if you look over on the y-axis, you see the provider count, and the y is the clients treated, x is clients treated. So for instance, if you look, let's say, in the middle of the 21 to 50, okay, you can see that 21 to 50 clients are treated, and the number of providers over on the provider count is just over 50. And if you break that down, that group, the number of providers represent 13% of the total number of providers, the 18.1% of all episodes, and the average episodes per client in that group is 2.3. So it varies from one end where providers have only 1 to 5 clients, way over to the far right where they have more than 101. And of course, the far right side accounts for majority of the percent of the episodes, 46%. Now we'll get into the next slide. If you have questions along this, please just send them in, and we'll answer them the best we can. This begins to show you, with concordant with evidence-based programs, the most frequent services provided, and they are non-medical interventions. So again, if you remember from that past slide, 19 million was the total spend for the 6 to 17 age group. And then as we move along, it shows you that assessments were about $1 million, testing was about $1 million, office visits, which was treatment by physicians, was $2 million. I'm going to go to the far right. $2 million was medication, and $13 million was for non-medication visits. And if you look at the footnote, you'll see that number 3, that non-medication interventions include all psychotherapy, counseling, community support, and therapeutic activities. So despite the fact that we've talked about this before, when we geared up before, that ODD, evidence-based ODD, is counseling, family counseling, therapy, non-medication, you can see that the total spend for this is $13 million for that area, and still there's $2 million for medication. This one shows who's providing that care of the $19 million. The total is $19 million, and that tiny little bar shows about $0.4 million is been treated by physicians, either PCPs or psychiatrists, but $18.5 million are being treated by behavioral health provider organizations. Okay? So the majority, we'll go back to that one for a second, the majority is being provided by behavioral health organizations, and you also can compare and contrast the episode count, is 190 versus 10,225, the total number of percent of episodes, so 98% of the episodes is represented by the behavioral health providers, and then the average cost for the episodes, which is $1,311 for physician, and for agency, $1,782. Okay, we wanted to compare and contrast as we move this along. Okay, next slide, please. As you can tell, I'm not capable of talking and moving the mouse at the same time, so Shelley's doing that for me. This next one, this graph shows that a third of the clients, 32%, are receiving care above and beyond what is recommended guideline and evidence-based treatment. And that middle area, those clients represent 63% of the spend, because if you follow the graph way out to the right where it says average cost, there are several episodes, several providers where the episodes are costing more than $14,000 per episode. And so if you go back towards the right, the episode count, the light blue bars, but also shows you the cost, and the cost is under $2,000 generally in that area. So it's this other area, that big percent of area that's causing 63% of the spend. Go to the next one. So that gives you some of the statistics about who's treating who, what the spend is, what the breakdown of the spend is. Now we want to go talk just a little bit about the guideline concordant treatment pathway for clients diagnosed with ODD. And I know most of you have seen this before. There has to be an assessment and diagnosis. And we're expecting a thorough assessment to be performed by a licensed clinician and confirms the diagnosis and is responsible for the care. And the parent and caregiver is notified of what's going on. And the treatment, the initial treatment plan is for 2 visits per week for 12 weeks based on evidence-based programs. And later on in the outcomes and indicators, Paula Miller will get into some of the things more specifically, so you'll see that this is these evidence-based and what Arkansas is expecting in terms of its outcomes and what we will be monitoring. So again, the initial treatment plan is 2 visits per week for 12 weeks. The expectation is about 40% of children will improve, and those that don't, you reassess those that don't improve. And so you go back to a second treatment, another 2 visits per week for 12 weeks, and the expectation is another 30% will improve, and reassess those that do not improve. But I really want to underscore the reassessment part, because there are many times that ODD may be the diagnosis, but this gives you an opportunity to really drill down on the diagnosis and make sure that this is what you're treating and only what you're treating, and there isn't something comorbid. Now, the outcomes show what the effectiveness of treatment is, the reasons necessitating a second treatment plan, and the continuing care. And the next screen will show you a little bit of the sort of a diagram of the pathway. So the episode is 90 days, and it's a single severity level as opposed to ADHD, which has 2 severity levels, and it's a year long. This is a 90-day episode with 1 single severity level and a single certification at the beginning of each episode. So if you follow along, I mentioned an assessment of a new client, which triggers a quality assessment certification. And then you go into the 90-day episode which is ODD only, no behavioral comorbid conditions. And the treatment, again, is behavioral therapy, psychotherapy, family therapy. You don't see medication listed there. And client remission on the far right. And again, as we talked about, 40% are expected to improve. And for the others, you go back and do another continuing care certification and start that clinical pathway over again. And here is with the DSM criteria for ODD, and 4 and 5 have not changed. In fact, this is basically the same for DSM-5. And the description up there is at least 4 symptoms for any of the 5 categories over a 6-month period, at least weekly or almost daily if they're under 5. And they basically fall into 3 different categories. The first one is the angry, irritable mood. It loses temper, is touchy or easily annoyed, is angry and resentful, most of the way I feel on Monday morning. The second one is argumentative, defiant in behavior. It argues with authority figures and adults. Actively defies or refuses to comply with requests from authority figures or rules. Deliberately, remember that, annoys others. Blames others for mistakes and misbehavior. And then there's a category that's vindictiveness, and has been spiteful and vindictive twice in the past 6 months. Under B, symptoms must cause clinically significant impairment in school, social, educational, or vocational activities. C, the disturbance is not solely due to another diagnosis such as psychosis, substance abuse, or depression. And D, the criteria not met for conduct disorder, and if the individual is 18 years or older, criteria not met for antisocial personality disorder. And here are the principal accountable providers. And these are the providers who are eligible to serve as PAPs. We have primary care physicians, pediatricians and family practice physicians, psychiatrists who are individual practiced or with behavioral health provider organizations, licensed clinical psychologists in individual practice. Again, since this is a non-medication episode, psychologists are included in this one as they were not included as the PAP in ADHD. So we have PhDs or PsyDs, or we have behavioral health provider organizations, and the behavioral health billing organization will be the principal accountable provider. And remember, providers will bill their claims in the same manner as today. There's no difference in that, okay? And at the bottom of the page, it shows who's eligible to provide care but not to serve as PAPs. Advanced practice nurses, licensed clinical social workers, school psychologist specialists, other licensed mental health professionals, and mental health paraprofessionals within behavioral health organizations. And again, it says certification requirements forthcoming. And of course, many of you have heard what we're working on in terms of our competencies for that. This is the PAP attribution logic. Sounds geometric or calculus, doesn't it? So physicians, psychiatrists, and licensed clinical psychologists are eligible to serve as the principal accountable provider, as we just mentioned in the previous slide. And if only one PAP eligible provider treats a client, that provider is automatically assigned as the PAP. If multiple PAP eligible providers treat a client, the provider submitting the most claims will be assigned the PAP. If 2 PAPs have the same number of claims, the provider with a higher spend will be assigned the PAP. If the client is treated by clinicians billing under a behavioral health provider organization, the behavioral health provider billing organization will be the PAP. Okay. We want to talk a little bit about thresholds and gain and risk sharing. And a PAP will fall into one of 4 categories depending on the provider's average cost per episodes. So A, and really A usually means good, but this doesn't mean good. Maybe it should be labeled backwards, but anyway, these providers are over-treating beyond the acceptable threshold and are subject to downside risk share of costs in excess of this level. And it says shown by a red arrow, which I don't see a red arrow. Make believe there's a red arrow. But you can follow the acceptable threshold, the commendable, and the upper limit, and this provider is above the acceptable threshold of $26.71. Okay? B is a provider who neither gains nor loses because costs are neither above the acceptable threshold nor below the commendable threshold. They're in a perfectly fine spot there. Now C is someone who's between the commendable and upper limit, and the savings below the commendable threshold are shared between the provider and payer until the upper limit is reached. Okay? So think about if the commendable threshold is $1,642, if a provider comes in at $1,500, which is below the commendable, and the upper limit is $550, there's going to be a gain sharing between those limits. And if you see that little circle or ellipse over on the right-hand side, gain sharing and risk sharing percentage is 50%. Provider D, is below the upper limit. And once the upper limit for savings is reached, the provider receives savings only up to the upper limit level. So he could be spending $335, but $552 is the upper limit, and we'll see savings only up to the upper limit level, which I think are shared at 50%. Okay? So these are Shelley's trigger is faster than my brain. So these are the thresholds to think about. Okay?
Thank you, Dr. Miller. Now we're going to turn things over to Trish Gann, who will talk to us about the episode certification. Again, a reminder, please enter your questions in the chat box if you have any questions.
Thank you, Shelley. We're going to go over the quality metrics or the quality assessment certification for the ODD episode. So first of all, just who is going to need the quality assessment certification? All clients new to ODD treatment or entering their first episode model are going to require that quality assessment. And if you remember back when Dr. Miller was talking about those pathways, then the first thing you're going to do is the completion of that quality assessment certification. And just a little bit different than with the ADHD episode, this episode's 90 days, and so you're just going to have to remember to complete these certifications for them. So the completion details you're going to complete after assessment to initiate treatment, and it's completed by the PAP who's going to deliver care. And as always, we just kind of caution people that you should go in and complete your quality metrics because just because you don't think you're going to be the PAP, you still may be. So it's important to complete those. If you go back a few slides where Dr. Miller was talking about the PAP, in order to participate in gain sharing, you will need to have completed these in 90% of those episodes. So that's going to be real important if you're going to be eligible for gain sharing. And whether or not you complete them, you will still be eligible for risk sharing. So it requires the PAP to certify completion of some guideline concordant components of the assessment. Really the hope is to encourage people to do a thoughtful and high-quality diagnostic or assessment and to encourage appropriate diagnosis of comorbid conditions. And then after that, at the end of the 90-day period, if they're going to remain, then there's going to be a continuing care certification. So that's all oppositional defiant clients within that episode model are going to require the completion of a continuing care certification. It's completed at every episode recurrence, so it's completed every 90 days, and by the person who will continue to be the PAP or who's going to be the PAP. Requires adherence to basic quality of care measures and guideline concordant care. It's going to really encourage reassessment of those beneficiaries to ensure that there are not complicating or comorbidities, and encourage regular reevaluation of the client and the effectiveness of therapy. And it's also a good opportunity to remind parents about treatment, about their cooperation or their being involved in treatment. So, the quality assessment, these should be completed. Hereby certifies and attests that this client has been diagnosed with oppositional defiant disorder. and have completed and documented the following in this diagnosis: that it was an in-person assessment, that this client or beneficiary has been evaluated in accordance with DSM criteria. And like Dr. Miller said, there's been no change in the DSM criteria for oppositional defiant disorder. So in that I found, then that should be a number 4 or higher. Right, Dr. Miller? No. For present for at least 6 months. Also, that there's been the use of some type of comprehensive assessment, broadband diagnostic or similar tool, and client family history that is going to screen for common comorbidities. That the parent or guardian has been informed of the diagnosis and informed of the importance of family involvement, and that they've also been provided a chance to express comments about the treatment plan, or that there are documented barriers to providing this information. And then I've initiated obtaining information that a screen or assessment for learning disabilities or language impairments has been performed in the last 2 years. Notice that says initiated obtaining information, that that's been performed within the last 2 years by communicating with the client, parent, the guardians, the caregivers, teachers, doctors, reviewing school or medical records, or that I've completed or arranged for and documented a screening for learning disabilities and language impairments. For the continuing care certification, you're going to certify and attest that you've completed and documented the following: that the client or beneficiary has been evaluated for ongoing symptoms, impairment, and activities to determine the continued necessity for treatment of ODD, using reports from at least 2 settings, that they've been rescreened for comorbid behavioral health conditions using some type of broadband or similar tool, that you've informed the parent or guardian of that need for ongoing treatment, continued importance of family involvement, and provided a chance for them to express comments, or once again that you've documented the barriers to providing this information, that you've at this point obtained information about a screen or assessment for learning disabilities or language impairments that was performed within the last 2 years, or that you've completed or arranged for or documented a screening for learning disabilities and language impairments, and certifying that you're providing guideline concordant behavioral health therapy, or if there's a rationale for providing care outside of guideline concordant therapy, then you've documented in the client record the need for that and the rationale for providing care outside of that. And that's all. We'll go.
Thank you, Trish. Now Paula Miller will give us the episode design and talk about the report.
Thank you, Shelley, and thank everyone for joining us today. We're going to first look at the ODD design, episode design. The episode is defined as any ODD treatment defined by a primary diagnosis, the ICD-9 code of 313.81, with the exception of the initial CPT assessment, the initial assessment CPT codes. ODD episodes are triggered by 3 medical claims with a primary diagnosis of ODD. The episode begins on the first day of treatment. For reoccurring clients, the new episode starts on the date of the first treatment after a previous episode ends. The episode will have a duration of 90 days beginning at the time of the first trigger claim. Claims for a beneficiary are tracked for 180 days following the closure of the 90-day standard episode to determine the episode readmission rate quality metric. We'll talk about more of the quality metrics in just a moment. Exclusions. Episodes meeting one or more of the following criteria will be excluded: beneficiaries not continuously enrolled in Medicaid during the 90-day episode, beneficiaries with any behavioral health comorbid condition, and beneficiaries age 5 or younger and beneficiaries age 18 or older at the time of the initial claim. The principal account provider, Dr. Miller alluded to this earlier. You've got your PCP, psychiatrist, or licensed clinical psychologist eligible to be the PAP, and the behavioral health provider organization will be official PAP when listing as a billing provider. Quality metrics required for gain sharing payment. Percentage of episodes with continuing care or quality assessment certification. These will be done in the portal on AHIN, and you have to have at least 90% of those documented in AHIN in order to be eligible for gain sharing payment. We're going to look at the percentage of new episodes with medication. That's a 20% maximum. Percentage of repeat episodes with medication, that should be 0%, and a percentage of episodes resulting in readmission, that should be a 40% minimum. There are metrics for reporting only. In other words, these will not be linked to gain share, but we are tracking these for reporting purposes. Percentage of episodes with a minimum of 10 visits, and percentage of episodes that are not guideline concordant, and percentage of episodes with a minimum of 8 family visits. We're tracking some utilization metrics, the average number of visits per episode, and the average number of behavioral therapy visits per episode. Remember, you must meet the quality metrics in order to participate in gain sharing. So that's very important that you pay close attention to those gain sharing metrics. Again, the episode begins with the beneficiary's first billable treatment for ODD, the first trigger claim, and the ICD-9 code is listed there. It's 313.81. The episode is 90 days. Some of this is a repeat, so just bear with me. I just want to make sure everybody understands how the episode was designed. All medical services provided during the duration of the episode are included to calculate the episode cost for evaluation against cost thresholds. It includes all office visits, psychotherapy, regardless of whether the care is guideline concordant. The initial assessment before the trigger date is excluded from the episode to encourage complete and thorough diagnosis. If the assessment is done during the episode, it will be included in the cost of the episode. The medications are excluded from the episode, but utilization will be monitored as a quality metric to determine gain sharing eligibility. And PAPs may utilize MHPPs as defined by the RSPMI manual. This next page is one that I use a lot, and I call it my at-a-glance page. And it is located on our Payment Initiative website. It lists kind of everything involved with the episode in one page, and at a glance. It contains information we've gone over on and you can use it as a quick reference. The page it gives you the particulars of the episode, such as triggers, exclusions, the episode windows, what claims are included, your quality measures and adjustments. The one thing that we haven't talked about, you have to have a minimum caseload of 5 cases in a 12-month period. But again, this page right here is located on our website, and it is a good reference page. You might want to, print out, hang somewhere where you can get it at a close when you have questions. Now let's look at the reports. The first page of the report that you'll receive concerning your performance is going to be an historical report. There will be performance reports, but let's look at this as a sample of the historical report. It'll give you the date of the report and the date range of the data included in the report. In other words, in this example, it's data collected from July the 1st of 2012 to June 30th of 2013. And please note the disclaimer on the bottom of the report that this information contained in these reports is intended solely for use in the administration of the Medicaid program. The data in the reports is neither intended nor suitable for other uses, including the selection of a healthcare provider, and the figures in this report are preliminary and are subject to revision. And for more information, you can visit our website at www.paymentinitiative.org. The second page that you'll have on your report is a letter from Andy Allison, the Medicaid Director. It has a lot of useful information in this letter concerning the payment initiative. Also, if you will notice in this report, it will also tell you if this report is in the preparatory or historical period, or if it is a performance report. So a lot of times you're going to be getting a lot of reports all at once, and it's going to get confusing. Is this historical? Is this a performance report? So you can always check back on this page and see if you have any questions. The next page is your table of contents. Now, it's going to list every episode for which you're considered a principal account provider. Now, I've listed all of them here just for example's sake, but when you get your report, it is only going to list the ones where you are a principal account provider. It's also going to list the dates for each episode where the data was included. For instance, you'll see with ODD, the data was January 1st, 2012 through December 31st, 2012 on this one, just to show you if there's any difference in the episode data. The performance summary. Again, it'll list all the episodes for which you're considered a PAP. Going across the column, it'll show the episodes of care, quality of service, whether you've met your quality metrics, not met your quality metrics, or if there were not any quality metrics associated with that episode. The next column is your average episode cost. Was it acceptable? Was it not acceptable? Was it commendable? And you can see that for each episode. Your gain or risk share. Are you not eligible for gain share? Are you subject to risk sharing? Will you receive gain share? It will tell you for each episode. And I'll also show the amount of gain or risk sharing. You'll see on this example, there is a risk share of $3,000 on the URI episode, but there is a gain share of $349.50 on the sinusitis. At the bottom, and this is not quite correct because it is a sample report, it will tell you, give you a summary of your risk gain share and if stop loss was applied. And if you will remember from the probably in the glossary or in the manual, you'll see that stop loss is the maximum cost sharing that a provider is allowed to bear in any given period, and it's capped at 10% of the Medicaid reimbursement for that period, and so it keeps you from getting hit too awfully hard. This page is very, very important in your report, and it's going to give you a whole lot of information concerning your performance. The first section is the overview. It's going to tell you the total number of episodes. In this example, 262. The total number of episodes that were included, 233, and total number excluded, 29. Remember, an episode can be excluded for any number of reasons. Could be age, it could be a comorbidity, it could be non-continuous insurance. So that's going to tell you how many were excluded. The second section is the cost of care compared to other providers. The individual provider is the darker blue diamond, and all other providers are in the light blue triangle. It gives you the commendable to not acceptable cost ranges. In this example, the provider falls into the acceptable range and is not subject to risk or gain sharing, which you can see in this section. The quality summary, this section of the report is divided into two parts. On this side of the black line, you're going to see those that are linked to gain share, the quality metrics that are linked to gain share, and on this side, the ones that we are tracking that are not linked to gain share. Since this is historical data, there's no quality metrics pulled from the provider portal, so this sample report will only show you those quality metrics that are pulled from claims. But remember, there are 4 quality metrics linked to GainShare that will show on your performance report. Remember, it's very, very important that you enter the required data in the portal, for even if you are in the commendable level cost range and do not meet the quality metrics, you are not eligible for GainSharing. So this side of the black line, you will have the quality metrics linked to GainShare, percentage of episodes with completed certifications, percentage of new episodes with medication, percentage of repeat episodes with medication, and percentage of episodes resulting in admission. And these can be taken from claims data, so there's nothing you have to enter in the portal for some of these quality metrics. The other side of the black line reflects quality metrics that are being tracked through claims but not linked to GainSharing, percentage of episodes with a minimum of 10 visits, percentage of episodes with a minimum of 8 family visits, and percentage of episodes that are not guideline concordant. Section 4 is the cost summary. There are several graphs in this section of the report that will be useful to you in assessing your performance. The first graph is the total cost overview. You can look at your total cost compared to your total adjusted cost. The second graph, the graph next to it, is the average cost overview. Remember, we are looking at average cost of the episode. So this particular one is very important. And this one, the individual provider is at $2,000. All other providers are at $1,750. So it's real close. It's still in the acceptable level, which is good. The next graph in this section shows your cost distribution. In this example, the provider had 23 beneficiaries in the $1,097 range to $1,642 range. He also had 23 beneficiaries in the $2,671 range to the $5,943, which is in the not acceptable range, as well as 84 beneficiaries kind of midway in the acceptable range. So if you get your report and you see that you have a large number in the non-acceptable range here, you might want to take a closer look at those beneficiaries on the detail section of the report that we will look at in just a few moments, and kind of do a little deeper dive into what made that cost higher for those particular beneficiaries. The last graph in this section shows the provider where they fall in the distribution range of providers' average cost. You can't see it very well on the screen, but when you get your report, you'll be able to see it a lot better, I promise. The individual provider is shown with a blue line in the graph, so you see he's right there in the acceptable level. The last section on this page is the key utilization metrics. These are things that we are tracking. The first one is the average number of visits per episode. The individual providers in the darker blue, all other providers are in the lighter blue. So you'll see these are somewhat close. The other thing is that we're looking at is the average number of behavioral visits per episode. In this example, the individual provider had 11, while all other providers had 7. So that's another thing that you can look at to see where there may be ways to improve performance. The next page is an additional graph of the quality and utilization metrics with percentages and provider distribution. This is going to show you just the percentage graphs of the things that we looked at on the previous page. The cost detail section. This is a very useful page of your report, and it gives you a more detailed insight of your cost distribution. It is broken down into the major care categories for the episodes, such as outpatient professional, pharmacy, emergency department, outpatient lab. This page also shows you how your costs in these categories compare to other providers. The individual providers in the dark blue again, and other providers in the light blue. And again, this section of the report can assist you in seeing where you're doing well or where improvements could be made to improve your performance. Next, you will see a detailed section where the costs are broken down by beneficiary. In this section, you will see the beneficiary name, which is not very clear right here, but they're fake names anyway, so we're okay. You're going to see a beneficiary name. You're going to see quality standards met or not met. You're going to see your episode start and end date, your non-adjusted cost, and your cost. And then what it's going to do for each one of your beneficiaries, it's going to break it down by the care categories that we saw on the previous page. It's going to break it down by cost and number of claims for each one of those categories. So if you look at this and you see beneficiaries that are in that high cost range on that previous graph, you might want to look at where those costs came in for that beneficiary and take a closer look at that. After the details section, you'll see a glossary of terms which will assist you in understanding some of the terms of the report. The last slide we want to look at is a timeline overview for the ODD episode of care. This shows you the timeline for historical reports that you will want to view your performance, and if necessary, make changes to transform your performance to the acceptable or gain-sharing level. Or if you are already at that gain-sharing level, maybe perhaps share some best practices with other providers. So it's very, very important that you look at your historical reports to kind of see where your practice is before the performance period kicks in. This list also shows you the performance periods and when to expect the payment reports. I know this is a lot of information, and if you have any problems accessing your reports or have any questions about the reports, please contact us via the phone or email. We'll be happy to help you.